Patient number one is Abby. Abby is 25 years old and was diagnosed with stage 2 breast cancer. She has had a hard time mentally with such tough treatments and has a previous history of mental health issues. She had a lumpectomy to combat her breast cancer and followed by 3 rounds of chemotherapy. She also has a good support system from her boyfriend, which is important.
So this patient, Abby, she most likely had a small tumor, which allowed them to do a lumpectomy. So even for all breast cancer patients, the options are lumpectomy versus mastectomy. Now, if the tumor size is small enough, then they sometimes can be treated with just removing the actual tumor itself and some normal benign breast tissue around it. If some women choose to, they can still get a mastectomy though as well. But this woman had a lumpectomy, and then usually if you have a lumpectomy, you get radiation as well. Because when you worry about breast cancer, you worry about future for local recurrence, where it could come back to actually the breast itself if it's left behind, or spread or metastasize to other parts of your body. And with lumpectomy, you're obviously not removing the entire breast, so you're worried more about local recurrence as well. And so radiation to the breast helps reduce that local recurrence down to the same rate as what a mastectomy does. So she would have had radiation as well. And now when people have radiation in this situation after lumpectomy, that breast that they had that treatment to will be a lot smaller because volume was taken out with the lumpectomy. And radiation also causes a lot of atrophy of the breast tissue and skin. So that breast will, sometimes we see women who are about half the size on that one side. And they would like to have reconstructive surgery to try to make that side bigger. The issue with that is radiation causes, it's great to minimize local recurrence, but it really damages the blood supply to the tissue, the skin. The elasticity of the tissue is not the same. So it's really hard to get a really good result for them with putting an implant in or doing some kind of fat transfer. Usually the long-term results of that are very poor. So in these situations, what we end up doing is something to the other side that has not been touched yet, has had no surgery or treatment to it. And what we most often do is a reduction to that side to kind of make it more lifted and match the size. We could also just do a lift alone. If it's just that radiated side has gotten more firm and perky, then we can do a lift to actually kind of make that match. But most commonly it's a reduction where we kind of take out tissue on purpose to the other side and do a lift there to make it match and have better symmetry long term. And usually those results last for quite a while. Now as time goes on, if it wasn't for gravity, I wouldn't have a job. So things will age and things will want to fall. The radiated side, the tissue there is just not the same and not as healthy as your normal skin, so that side will stay perky for longer, and your natural side that's not had radiated is going to fall more. So a lot of these women will have to get a repeat lift, usually 10 to 15 years down the road, to kind of help keep that symmetry where they want it to be.
Patient number 2 is Alex. She had a late diagnosis of stage 4 breast cancer. She also has osteopenia, which means weakened bones. Because of that, she experiences severe pain with broken bones in her back. Her cancer was treated with systemic chemotherapy and then followed by local radiation. She has a very active lifestyle. She swims and dances. She was 36 years of age.
So this second patient, Alex, she presented, sounds like very late in this picture of things, so she has stage 4 tumor. And usually when people have that, they have metastasis, and that she had some to her bones, and a lot of them can have like fractures, what they call pathologic fracture, where the actual bone has fractured from a tumor kind of replacing the normal bony structure. And so when we see women like this who've gone through so much treatment, chemotherapy, radiation, and have metastatic disease, the initial thing that we, as a reconstructive surgeon, we don't want to throw more hurdles in their way of trying to get better, right? So any surgery that we do, whether it's implant reconstruction or using their own tissue to kind of make a new breast out of, all those surgeries have a complication rate to them. No matter how good of a surgeon you are, sometimes people don't heal as well, people can have bleeding issues, and the last thing you want to do is a reconstructive surgery for these patients and basically impact their ability to kind of recuperate and get better from the cancer. And a lot of these women too is stage 4 disease. So when you look at any kind of cancer, you're looking at usually what they call 5-year mortality rates or survival rates. And a lot of these women with really aggressive bad tumors, their 5-year survival rate is very low, unfortunately. And so do we really want to be exposing these people to more surgeries and potential complications and issues when they really only have a few years of life left, and we'd rather not give them those kind of complications and problems or expose them to those potential things as well. So for a woman like this who probably has a very low 5-year survival rate, we sort of have more of a minimal approach to those kind of things for sure.
Patient number 3 is Maya. Maya is 46 years old and was diagnosed with an invasive lobular carcinoma. She works as an elementary school teacher and is a mother to 3 children at home. Her cancer was treated with surgery, chemotherapy, and radiation, which was followed by hormone therapy. She also deals with a weakened immune system, which affects her treatment.
This last patient, Maya, she's 45 and has invasive lobular carcinoma. There's different kinds of breast cancer. Invasive lobular carcinoma is one that's been shown to be more likely to go to both breasts. So most cancers, like invasive ductal, is probably the most common breast cancer, and that's usually one side. 1 out of 8 women get breast cancer. Invasive lobular is a different type of breast cancer. There is some data showing that you are more likely to have it on both sides. So a lot of people in this situation will get a bilateral or both sides mastectomy, so both their breasts will be removed. And she had radiation after her mastectomy. And so radiation, like we talked about with the other patient, really impacts the elasticity to the skin and how well the skin responds to any kind of reconstructive surgery. So how we usually approach reconstruction, there's 2 different steps, 2 different types. One's implant-based reconstruction, and the other is using your own tissue. So with a mastectomy, you're obviously flat on that side. And so what we have to do is kind of stretch out and make a new space for an implant to go. So to do that, we put a tissue expander in. That goes in underneath your pec muscle, and we close everything up after that, and we slowly fill that up, which stretches out and makes a new breast shape for the patient. Now the expander is really hard and firm, and so we don't leave that as the final result. So once they're expanded to the size that they want, we go through the same incision, take that out, and put the final soft implant in, which is a much easier step. So it's a 2-step procedure. Now with radiation, if they come to our office already having a mastectomy and radiation, that skin, they're flat on that side. That skin is very tight and does not have that elasticity to it. So if you try to put an expander in and stretch that out, there's over a 70% failure rate because that skin just doesn't want to stretch. The rib cage will actually kind of push back more because the ribs will have more mobility than the actual skin will. So usually we end up having to replace some of that radiated skin with some healthy tissue from nearby. So the options with that are we usually remove in the lips or some of that radiated skin on the chest wall, and we bring in some healthy tissue from your abdomen or stomach or back, and we kind of bring that around and replace that radiated tissue, and we put an expander behind that healthy new tissue, and we slowly stretch that out and do a very similar process of stretching that out until they get to the size that they want, and then we take that out, put the final soft implant in. So having radiation does mean you have a little bit more of a reconstructive process usually, because we just can't put the expander implant by itself. We usually need to remove some of that radiated tissue and replace it with some healthy tissue. And we call those surgeries flap surgeries because we're basically taking tissue from somewhere else on your body and rotating it or moving it around into where you need it to be. And for these people, it's in their chest. It was a pleasure having Abigail Schultz come shadow me. So she came once a week to the office, starting, I think it started September to March was the time frame. So once a week at the office, she got to meet a lot of breast cancer patients, kind of the consult with them, the process of how we discuss with them the reconstructive issues that they may go through, and kind of helping them go through those steps. Usually she saw some patients in the very beginning, like when they first met us, and then as they were getting expanded and having their tissue expander filled, and then some people at the very end of their process as well. And then she also would come once a week to the operating room and see a lot of these surgeries that we do, and kind of was able to watch and observe a lot of those cases. So she got to learn a lot in both the operating room setting and the clinic setting.
I would like to thank Dr. Rob Shaw for giving me such a great opportunity and learning experience. I am far more excited to become a surgeon now that I've seen how awesome he is at it.